Thank you, Mr. Chairman, ladies and gentlemen. I don't think I'll be able to speak as eloquently or as fast as the last speaker because while skiing yesterday, somebody ran into me at full speed and I was actually knocked unconscious for a while. And true story, and when I woke up, the ski patrol said I thought I was in somewhere else like Italy because when they asked if I wanted water, I mentioned something about an Aperola spritz or something. So they kept me and I feel better now, so it should be okay. And my wife gave me a neuro exam last night, which to her was just making sure I hadn't turned into a Trump supporter, and that was fine for her. So anyway, we should do fine here. So what are we talking about screening for cardiovascular risk? You know, we're talking about there's a lot of injury and disease can exist for many years before you really see it overtly. And the idea would be, can you use biomarkers to help identify those who are at risk for developing heart disease? That could be heart failure, occult LV dysfunction, ACS, a lot of other things. But when we talk about screening, you know, who should we really go after? Someone once said that a normal individual is just a person who's really not been sufficiently examined. You know, in other words, if we look really hard, we're going to find something. If you see this, do you really need to screen, right? Because they're probably going to end up like this. So we want to pick in a cost-effective way who we want. And that means we want to take people when they're younger, maybe with risk factors for disease, so that we can start off either therapy or to reduce those risk factors or start into an exercise protocol, which hopefully would be better than this one. And the biomarkers that we should really want to use are those that are elevated, not the 99th percentile, but you can detect them. They're detectable early, and they go up as you get asymptomatic disease, clinical disease, and severe disease. This is what we want, and guess what? There's 3 around right now that do that job, BMP, troponin, and ST2. I'm going to start with BMP. The natriuretic peptides, they're really the standard for the diagnosis, and I helped work on that for a lot of years, and I suffered a lot through that. In fact, in my cardiology heart failure guys, they never thought we needed a biomarker for heart failure because they knew how to do it, they said. And so my kids weren't even invited to their kids' birthday parties anymore, and it got pretty bad. So I am a writer. I write some novels. You could look them up. But so I wanted someone to say BMP in front of my face. So I wrote a script for the TV show ER, and they took it. And they didn't take all of it, but I'm just going to show you like a 10-second piece where I got somebody finally to say that BMP.
And I told you to go home.
BP 195 over 105, heart rate 115, RAS 30, SATs 93.
CBC, troponin, Chem 7, and card suggested BNP.
What the hell is that?
B-type natriuretic peptide.
Okay, that was fine. You know, I was sort of happy with that. And you know, for all the backside of this Mount Rushmore is really testimony to all the BMP doubters, you know, because it's here now. But the thing is that BMP starts, these talks you heard earlier about vascular disease, it starts being elevated very, very early. And it goes on through the vascular disease, LVH, MI, enlargement, remodeling, clinical heart failure. When you die, well, finally goes back down to 0. We can take advantage of that. You know, and in fact, if you look at some studies, this is a Framingham community study, over 3,000 subjects followed at about 5 years. And you can see that if you look here, this is on the left, it's a hazard ratio for 1 standard deviation increment. And on the right, adjusted hazard ratio for over the 80th percentile. You know, threefold hazard risk of developing heart failure with a very normal looking BNP. Here it is again by baseline BNP, the highest third, which is really in men about 13. So that's well below the current threshold to diagnose heart failure. Now, the distribution of BNP is shown here in those with LV dysfunction in the black and those without LV dysfunction. And you can see that there's some pretty good room to suggest that this can be used in screening. In fact, if you look at this as a summary of the studies, with not all of them, but most of them, screening for LV dysfunction, and there's various EFs they looked at, but the area under the ROC curves are generally between about 0.7 and about 0.85. And if you look, and this is another study, it's sort of a meta-analysis, but looking, this is where you could refer these people from the echo lab, from nuclear lab, from the laboratory to use that BMP to generate risk. So let's fast forward to the European guidelines. If you see a patient in the office that could have heart failure, have some symptoms of it, and right down here, you can measure the natriuretic peptides, which is good, and it should be there, though they got the wrong numbers, to be honest with you. The BMP is fine. 35 is low, but if you're false positive, it doesn't get you a biopsy, it gets you an echo. But the NT-pro is too low because 80-year-old people have an average level of about 150, and yet they're saying screen at 125. So what's going to come out soon is probably an age-related cut point as to how to use this in screening. The best thing is really to understand that the positive predictive value of the biomarkers here aren't great. The negative predictive are pretty good. So this is where you can take these higher risk individuals, potentially rule them out. And if you have it pretty high, what are you going to do? A echo, maybe a referral. This has been done. The Stop Heart Failure trial by Ken McDonald in Ireland, very simple, followed 600 patients, routine care, and another group with BMP directed care, meant that in the directed care group, they would get every year a BMP. Now, they use 50 picogram per mil, and if it was over that or that at any time, that would trigger a cardiology consult, an echo, and some nurse coaching. The endpoints were echo changes and hospitalization. And it turned out the results showed there was a reduction in diastolic, systolic dysfunction by echo, and clinical heart failure. And when you ask why, those patients in the BMP trigger group were on ACE inhibitors, mineralocorticoid antagonists, beta blockers much more often. Now let's move from that biomarker to the high sensitive troponins. Now I talk a lot about this. Usually I fight with the ED docs because we have sort of different opinions of what you want to do with this. But with the high sensitive troponin, understand that, the definition ensures that at least 50% of the population can get a reading. But you can actually now, as they're getting more and more sensitive, almost everybody, you can find a reading in the limit of detection. Now, what does that mean? Well, this is really, really interesting. I think, first of all, that if you have a troponin, and this is a meta-analysis looking from the ERIC study, for instance, that detectable in 67% here, and you follow them out a few years, usually 4 or 5 years, there is heart failure where there wasn't before. And in this study, it was minimally elevated. 0.003 microgram per liter is associated with an increased risk. Leave that study and go to the Maisel study of atherosclerosis, and there they looked at MRI, looked for scar later after getting an initial high-sense troponin value, and you can see that the higher that high-sense troponin was, the more often you saw a scar. And this wasn't from ischemic heart disease, this is more actually non-ischemic. This should give you pause. And if that doesn't, this will. We all learned in medical school Laplace's law, left ventricular hypertrophy, and pathophysiologic good or pathophysiologic bad. When do you cross a corner? We always study that at med school. We don't know. But sometimes Laplace fails, and when that maybe happens, you may get some ischemia going, and the troponin may go up. And this is really important, I think. This may be the link between physiologic and pathologic hypertrophy. Here, you look at a dose-dependent increase in troponin T here in proportion with well-defined LVH. The more the LVH, the higher the troponin. And this is the group that if you look at what that means over time, we turn that the physiologic to pathologic to perhaps malignant by looking at what happens if you have LVH and a high troponin. This is the hypertension people need to understand this. A lot of people need to understand what we should do with this. Well, one thing I know we should do if you're a physician, we see one person every marathon dying, and there's something to that, and most cardiologists have stopped running marathons because they know what happens. They know that at the end of a marathon that your troponin jerks up quite a bit. And this jerks up because this is echo study done. The LV is okay, but the right ventricle really looks bad. So what do? So we have to think about having this troponin in our screening and maybe modulating treatment. And as we get older, we're looking for things that tell us we're doing a good job, that we're not aging as much. And troponin may be perfect for this. Look at this. This is from this active study. You have NT-pro on the left, and you have high-sense troponin on the right. And what this is showing is it's showing that as the troponin after different periods of exercise and different amounts. So in other words, the more a person exercises, these are older people, the more they exercise, the less of a troponin rise they see over time. Does that mean anything? It sure does. Okay, because this is a study where they take the change in troponin baseline to, I think it was about a year, and they see how that relates to new onset heart failure. So the blue is a decrease in troponin over the time period. You can see that depending what your baseline, you didn't do much. But look over here. The red is people that over time had a 50% increase in their troponin level. And look what happened. So this, I think, is going to be warrant to be a really good, solid marker we're going to look at for risk. Now, the last one, which I think should be right there in primary care as well, is something called ST2. It was invented in a lab in Harvard. They stretched myocytes or fibroblasts along with myocytes, and they got a huge gene signal for ST2. But it turned out also to be the ligand really protects a pro-fibrotic pathway by dragging in IL-33 to block that, to block fibrosis, hypertrophy, all that stuff. But when something goes wrong, the ST2 or decoy receptors in the heart come out and they pull that away. So about numbers, if you want to hang your hat, we can't decide what number of BNP to hang our hat on to for screening, but 35 is a darn good number. 35 is a number that I could measure at everybody here, and if you're over that, I would definitely get an echo. And if you're not, mine's 12, which is really about where it should be. But let's start with young patients who are diabetic, and they follow them about 10 years to sort of determine who's at risk to develop cardiomyopathy. And you can see the results yourself. This marker of a pro-fibrotic pathway was the #1 predictor. This is important. Just as Ken McDonald in the STOP-HF trial used BNP as a screen, what I've done in our hospital is use the ST2. And if a primary care gets an ST2 and it's under 35, they look good. Trust me. My nurses throw them out of the heart failure clinic. If it's over, they can get an echo, a consult, or even learn how to follow them with antifibrotic medicines like Entresto, et cetera. So if you take studies, these are from some non-STEMI trials I'll show you, like Merlin TIMI 36. You take a baseline ST2, and you look above or below 35, and look at the risk of developing heart failure out to just about a year. It's significant. And here it's just broken down. On the left side, you see 30-day follow-up. On the right side, 1-year follow-up. And this first red box is where you actually include troponin here. It's still very significant. And on the bottom one, you include troponin plus BNP, and heart failure is still very significant. And in fact, if you put ST2 and BNP together, this gives you, and look at what heart failure at 30 days, it gives you a nice prediction. There's a bunch of other ones. The Clarity trial, which is a STEMI trial, looks at ST2 and NT-pro quartiles, all associated with future risk of heart failure. And if you put those together after the initial MI, look for early heart failure, and you look at the top quartile, the two of them, there's a 7-fold risk. So this is a really important biomarker. There are other fibrotic biomarkers around. I used to be a proponent of galectin-3. It's a good phenotype for fibrosis, but it doesn't change. In other words, you can't modify it no matter what you do. So ST2 is really a predictor not just of events, but of drug efficacy, drugs that have antifibrotic properties. The Ephesus trial, remember this trial? The people with acute STEMI plus heart failure were given a eplerenone or placebo, looking at death and remodeling and readmission and things like that. And this one study got eplerenone an indication for heart failure after an MI. Well, how does that work? Well, it turns out this slide is a secondary study, but it's one of the best secondaries I like. There's an echo study looking at end diastolic volume index. And guess what? It was only those people with the high ST2 levels that really had an effect from the aldo blocker. Think about it. Big MI, inflammation, profibrotic activation, the decoy receptors come rushing out of the heart. They suck up all the IL-33. That profibrotic pathway is open. You get remodeling, fibrosis, and death unless you block it with an antifibrotic drug. There are two, spironolactone, and of course the new drug, Entresto. And Entresto, actually, I'll talk a little bit about that tomorrow, in the Paradigm study showed a very nice correlation with the endpoints with ST2. Now, I think one of the best ways to go here as we move forward is biomarker panels, multiple marker panels, because you can put a number of different pathways in this panel, and you can overcome some individual limitations of an individual biomarker. Day-to-day, inter-individual stuff, assay precision, and you can get a broader scope. So you can put markers right now of strain, necrosis, fibrosis, renal dysfunction, inflammation. And if you put that together, and that negative predictive value will be good, and they're done. And if it's high, then you move on. They did this a bit in the Framingham Heart Study, about 3,500 patients. They built a score based on the three I talked about, ST2, BNP, troponin. They added CRP and GDF, followed about 11 years, and every quartile of rise showed this is an all-cause death, but you have a similar pattern for heart failure and other cardiovascular events. So this works. So the future, we're going to have genomics, we're going to have proteomics, RNAs, metabolomics, and looking at the microbiome. So right now, you could be driving down the highway, and if you're right in the middle here, and you're trying to decide which way to go, you see this one guy says, do not follow. So you get ready to move over, and the other truck says, move left. So what do? So it's a bit of a quandary. Who do we screen? How do we make this cost-effective in our cost-effective countries? A lot of people say, well, you got to partner screening with other kind of things. Why don't you get screened at the airport. Why don't we do healthcare with airport stuff? Here you got on the left, congratulations, you're having a boy and you're good to go, but you might want to get that pancreatic tumor check. There's a lot of ways we can put this together. In drugstores, we have things we're trying to use some smart apps in regular CVS and Walgreens drugstores in the United States where you push a few things in and you can get information and then maybe get a blood test. But listen, I'm not just talking. I walk the walk, okay? Because I believe in this kind of screening. I spent 3 years, at least 1 or 2 months a year, traveling over rural China with Hu Dai, the barefoot doctor of China. I think a few people, maybe Dr. Pfeffer knows him. And this guy was the biggest hero. I mean, wherever we went, they brought out everybody from that town for the parades. And I also brought, there's Mark Richards from New Zealand. I got Chris Filippi to do the echoes. And we went in the rural areas to screen adults and young people with heart disease. And when they announced it, you can see what a madhouse it would be. I was most interested in the kids. And the deal I made with the Chinese government, I'll come in and I'll screen all over. We'll go in the areas where there's a lot of valve disease in kids and they die. But if we pick a BNP level above a certain thing, and these are finger stick tests we use here, and then they would, and do the echo, show it, then they would go get an operation. So we did all the examinations, and they're the cutest little kids, and then, yeah, we brought a cardiac surgeon, and we sent about 100 kids to surgery. And the second screening thing I'm proud of was, I don't know if you know Hank Gathers, I know Mark Pfeffer and a few others. He was a great American basketball player from Loyola who collapsed during a game. And he had done collapse a few months before that, and they found an irregular heartbeat. He gave some medication, but continued playing, and then collapsed again, and you can see it on YouTube or so, and he died after his collapse. And what he had was hypertrophic cardiomyopathy. So this also you could pick up even with a screening BNP. It's always a little high. And in fact, we went to Loyola Marymount and did exactly that, screen all the athletes there. And I'll end with this. One of the people we screened had this little saying on his belly, tattooed. And it says, Lord, grant me the serenity to know the things I cannot change, the courage to change the things I can, and the knowledge to accept the difference. Thank you very much.